to University of New Mexico because they have a fantastic medical program and they focus on rural health. And I had spent my first 3 years of college there doing interning in the cancer center and was a cell bio major. And then I did a study abroad over to Scotland in King's College. And that experience completely shifted where I ended up with my degree in English and history. Because what I realized was I was watching for 3 years doctors treat one patient at a time. And it became kind of maddening to be like, oh my gosh, you have this whole sea of people and populations, and you're treating them one person at a time. And it just felt like whack-a-mole, if you remember that old game. And I didn't want to do that. I realized I had this kind of epiphany that no, I want to serve populations. How do I do that? How do I help swaths of people? And I realized that it's not necessarily having the medical like diagnosis and treating someone, but it is looking at what are key drivers, what are root causes of people becoming ill in the first place, and are there ways that we can look at making sure people get better access to care, and when they do get access to care, can we make sure that it is high quality care? How do we create cultures of high quality and safety? And that started to like really drive my interest. And so I switched my major my senior year to English and history. One, because English was, I'm a writer, I'm a communicator. And I thought, hey, if you're going to lead and you're going to help in the medical world space, whatever your role is, writing, reading, analyzing, policy, all those things are going to matter, right? And then the history part was more so just my nerdy love for all things history. And it can also be medical history. So I love to read about like the history of surgery, the history of different types of chronic diseases, the histories of different infectious diseases, the history of how medicine even became a thing. And so for me, understanding the context, whether that be of a culture that I'm working with, or whether that be of a type of medical prevention, I think understanding the historical context of it, the good, the bad, and the ugly of all of it, helps you understand how to be able to work in the current. And even vaccines are a great example of that. I mean, there is some horrible history there of what had been done to certain vulnerable populations and how that was done, years ago. But if you understand that and you've read up on it and you've interviewed people, right, then it's better for you to be able to understand how to implement, let's say, vaccines today, right? And so I really always like to tell students that I'm working with, don't ever think that one degree is going to make, oh, this is the perfect degree that's going to make you be a great public health practitioner or a great medical student. Any degree that you can apply transferable skills to is going to make you great at what you do because you're bringing in what your natural talent and skill set is.
And I'm hearing this often, like more often now, is that like, especially when people are talking about in the context of students that they're speaking with, is students are like, they have the skill sets, but most of them might only focus on building the skill sets and the core competencies, but lack the historical or cultural context and awareness of things. And I think that in itself is maybe a disservice to themselves in not being able to really fully grasp the situation that is at hand and understand all the nuances in it. Yes, the skill sets are important, but how has the cultural context and historical context of a situation really played into how things are? And that's what I'm thinking about a lot more, because you are the second person to say this over like a 2-week time span. So I appreciate you raising that up. And for the students that are listening, like listen to that and like learn more about the historical context of whatever you're interested in.
Mm-hmm. Interesting.
So you went on to get your Masters of Arts in English and Public Policy at Cal Poly San Luis Obispo. I hope I said that correctly.
Yeah.
And I think previous to this, you worked at UC Davis Health for a bit. So tell us about that, maybe a little bit about the work that you did at UC Davis Health and how that helped made you make the decision to get a Master's in Arts and English Public Policy.
So I actually did my master's first before I went up to UC Davis to work for them.
Okay.
But I did my master's in something that I knew that I would be strong in rather than focusing on, an MPH at the time, I focused on the niche of what I wanted to focus on, which is really focused on public policy, rhetoric. I was fascinated with human behaviors of if you really study rhetoric and you understand what is persuading whole swaths of populations into one direction or another, which I think is very relevant to today in watching different movements start and really take over different types of influencers, really. And so I felt like that was a really important part of the piece of the puzzle when we're talking about medical care and public health, because when we're talking about the medical world and public health, it's really personal, right? It's personal to everyone. Their own personal health. They all have a family member or a friend who's gone through something. And they all have these deeply, deeply personal stories. And how people choose to go about what they do or don't do for their own healthcare is really personal. And so how I was curious about, well, what part does policy and rhetoric and all these types of things of how do you persuade human behaviors toward one angle of health or not? And so that's why I really went toward that particular degree. And then I moved back closer to home. I moved up to Sacramento area, which is about an hour away from where I grew up, and worked for UC Davis for almost 15 years in multiple different capacities. And I think for me there, the most important, impactful lesson that I got out of that experience in working in a variety of different healthcare leadership roles was how do you create a culture of safety and quality? And I'm not talking about systems. We all have systems in our hospitals. We have, like, if you go in for a surgery, there is a long checklist of the doctor has to make sure, am I operating on the right leg, the right side, the right spot, using the right tools, the right technology? Like, there's a whole checklist, a whole safety list, just like pilots have a checklist before they take off. But there's something that can happen with these checklists and these rules, right, for infection control, is that if you do it day in and day out, that checklist can easily become, yeah, we did that. Oh, wait, we didn't do our huddle yet, but she'll be in here. I'll just click yes because I got the computer up, right? Things can happen where we're humans and it becomes familiar to the point where we start getting, lax or make some mistakes, or, oh, wait, we didn't, wear the proper, thing in the OR, and then all of a sudden there's an infection, or, oh, we didn't, prep this patient totally right, and there's an infection. Like, all these types of things that can happen. And so I was really laser focused on how do you make policy meet practice in a really meaningful way. And one example I'll give is I used to do rounds on the hospital. It's a huge hospital. It's an academic research hospital. And there was always this one area where they were kept on, like, propping open up their fire doors and stuff like that every single time I went in there. And so instead of just like saying, okay, this is another violation, I used to pause and I said, hey, out of curiosity, walk me through your patient pathway. Like, what do you do? And why is this always like, just tell me about what your thought process is. And they're like, well, it's just easier for us to then see the patient when they need something here and whatever. They had a whole thing. I said, oh, so it's just that you need to have a way to know when there's a patient in need or what level of the process they're at. And they're like, yeah. I said, okay. So what if we put together these little things on the wall that you were able to, like, flag out? And they're like, oh, that would work. And then I shared with them the reason why this fire door has to be closed is, when you're at home and you have a fire, you evacuate. When you have a fire in a hospital, which happens every day, you don't evacuate. They have to be shut because they're supposed to be locked in, right? And then the idea is that it sucks all the air out, and then you're able to contain the fire to one spot. And there was this aha moment in the nurses, and they're like, oh, we never thought of it that way. Like, it's just, but taking 5 minutes to understand or explain the why behind a policy, and then come up with a workaround that works with what that individual needed to be able to do their practice really well. Just that 5 minutes made a big difference in every little different interaction, right? And I think so often what people do is they try to shove policy down people's throat and then, flag them for it when, they don't do it right, rather than having a conversation that's bi-directional to understand what are the issues with that implementation and what are some workarounds, or what are ways to be able to get to, the why behind something. And then you see it's a shared practice.
I appreciate that example, and I think that that's important for people to listen to as well. I also appreciate you like saying, I could have gotten a master's of public health, but I was like, let me lead into something that I know that I'm good at, and like there's this other perspective. I feel like, and I think it's an important one that we don't talk about, like the rhetoric around public policy and how all of these, like, I don't know, movements or groups of people kind of collect around different ideas